Okay, my name is Natia Sarah, and I'm a psychiatrist lecturer. So today I deliver a few topics from the psychiatry. So let's start now. I'd like to share the presentation with you. Just a second. Sorry. Hello, hello. Wow. Why I can't share the presentation? Mm-hmm. Okay. Can you see the presentation, guys?
Yes.
Okay, very good. So once again, my name is Natia, and I'm a psychiatrist. And today you have a lecture with me. So let's start with the introduction to psychiatry. This is the first topic. We're going to talk about the general psychiatry. Of course, it will be a very brief lecture. Psychiatry is a pretty wide branch of medicine, and in 2 hours it's impossible to understand what the psychiatry is, but I will try to explain in brief the general concepts of the psychiatry. So first of all, what does it mean? What is the definition of a psychiatry? Psychiatry is a branch of medicine that deals with mental, emotional, or behavioral disorders. And of course, psychiatry deals not only with these disorders, but of course, it suggests treatment options for these disorders. Literally, psychiatry means healing of soul, or healing of mind. So, when we are talking about the psychiatry, of course, we have to understand the mental diagnosis, the symptoms of these diagnoses, the treatment options, and of course, we have to classify different mental disorders. We need some classification systems. So, in psychiatry, exist two classification systems in general, and this is the ICD-10. It is not a very specific for mental disorders, but still ICD-10 includes some mental disorders with its code. So what does it mean, the classifications, the general classification system? And this is the classification of different diseases, and it's international classification systems, and the psychiatrists from the different countries, when they share these classification systems, they can understand the codes of the diagnosis, the symptoms of the diagnosis, and this is like simplifies their experience and practice of psychiatry. So, in some countries, for example, in Georgia, we have ICD-10. We follow this classification system, but more specific is the DSM classification system, which is a diagnostic and statistical manual of mental disorders. It is a very specific classification system, which was created by the American Psychiatric Association, APA, it's called APA. The ICD-10 was founded by the WHO, or World Health Organization. So as to me, I prefer to follow the DSM classification because of the specificity to the mental disorders. So, well, it's a matter of policy of the particular country, which country follows which type of classification system. For example, in Georgia, we follow ICD-10, but personally, I prefer DSM classification system. So when we are talking about psychiatry, we understand that we are dealing with emotional, psychological, or behavior abnormalities. But first of all, we have to define what does it mean normal to define what is it abnormal, right? So it's very hard to define what does it mean normality. You know, there is no a clear definition of normality. Even the WHO does not give us the clear definition of the normality. It defines normality as a physical, mental, and social well-being. But of course, it is a very limited explanation and definition, and it explains normality like absence of physical or mental disease. But of course, this is a very limited explanation. As to DSM-5, DSM-5 also doesn't give us the clear definition of the normality, but it gives us the definition of abnormality. So from this point, we can discuss the normality. If we understand what does it mean abnormal, in that case, from that scope, we can discuss and judge what does it mean the normality. And according to DSM-5, a mental disorder is a syndrome which is characterized by clinically significant disturbance in individuals' cognition, emotion regulation, and behavior that reflects a dysfunction in psychological, biological, and developmental processes which is underlying the mental functioning. So in brief, what does it mean abnormality? Abnormality, yes. Yes, dear. Do you have a question? Okay. So in brief, abnormality is dysfunction in a different mental processes like cognition, emotion regulation, and behavior. And I'd like to tell you that there is a strong linkage between the mental states and its physiology, and a link between the cognition, emotion, and the behavior. Cognition or cognitive functions are it's a general term which includes thinking process, concentration, perception, and in mental disorders, all of these functions are suffering. So if you have abnormal perception, for example, of reality, which we have during the schizophrenia, of course, my emotions also will be abnormal and my behavior will be according to my abnormal emotions and my perception. So it's like a system. When one system is suffering, all the parts of the system are suffering at the same time. Well, when the person has a mental disorder, generally it's associated with significant distress in social, occupational, or in other important activities. When a person having this disorder, he cannot be socialized anymore. He's asocial. He cannot function properly in the society. Okay. Sometimes we need to differentiate abnormal behavior, which is determined due to the conflicts. Sometimes people have abnormal reactions to some specific situations, but it does not mean that they are mentally disabled or they have mental disorders, because it can be determined due to the culture. So it is a very relative, in some cultures, what we call normal behavior. In other cultures, it might be abnormal. So if, for example, the person from one culture, if he gets to another culture, he might have the different reaction to the situation, right? Or his reaction might be interpreted differently in other culture. So we need to take this into account by all means. to differentiate what is a true mental disorder and what is the abnormal reaction to the culturally specified situation. And the same I can tell you about the socially deviant behavior due to the political, religious, or sexual conflicts between the personalities. It might be because of the different worldviews. Some person might have his personal religious worldview, which might contradict with the worldviews of the other personalities, and because of that, he might have the deviant behavior, but it doesn't mean that he's mentally disabled. All these factors we should have to take into account when we are trying to make a diagnosis of the mental disorder. So, now I would like to focus on the main organ, which is the main target in the psychiatry. This organ is the brain. The brain is the, as you know, it's the most important part of the body which regulates the behavior. There is a linkage between the brain and behavior, and well, it is a control system for the body. It controls. It has the sensors. It controls the
Sorry, doctor.
inputs. And yes.
What book are you giving?
Book.
Yes,
Kaplan
what's the
and
name of the
Sedok.
book?
Kaplan and Sedok. You might find these, or maybe I will upload this book for you guys, okay? The brief version of Kaplan and Sedok Psychiatry.
Okay, thank you. Will you send us the PowerPoint
Mm-hmm.
also?
Yes, of course. Sure.
Okay, thank you very much.
I will ask to Salome on which portal I should upload this. Maybe I will upload this, or I will send it to you. I think that I will upload everything on a drive. So I will ask Salome.
Hello,
Okay,
doctor.
thanks.
Mm-hmm. And I will upload the book also. Okay. So, well, I'd like to remind you a little bit of information from the morphological structure from the nervous system, because the nervous system is also a target for psychiatry, and the basic functional morphological unit for the nervous system is the neuron, as you know. So as you see, neuron is built up with the cell body, with the axons, with dendrites, myelin sheath, and we know that the neurons are transmitting impulses. But while we are interested in the neuron, and what is the connection with the neuron, psychiatry, behavior, of course, there is a deep linkage between of these issues, and the neuron is the basic unit of the nervous system, which releases the neurotransmitters. And in psychiatry, mainly we are interested in neurotransmitters. I'd like to tell you that all mental disorders in a psychiatry are disorders of the neurotransmitters, or abnormal levels of the neurotransmitters cause the mental disorders. So neurotransmitters are main issue in a psychiatry. If you understand the functions of the neurotransmitters, you can understand almost all types of the mental disorders, and of course the specificity of the treatment, because the main treatment options are targeting these neurotransmitters and its receptors. So we have to know what neurotransmitters are specific for the mental disorders, what are their functions, and how we can regulate the levels of these neurotransmitters which cause the mental disorders. Abnormal levels of these different neurotransmitters cause the mental disorders. So, as you know, between the neurons there are synapses, junctions. Between the presynaptic neuron and the postsynaptic neurons, we have two types of synapses, excitatory and inhibitory. And we have two types of synaptic transmission, electrical and chemical. And the operation of the synapses is unidirectional. It means that from the presynaptic neuron, impulses goes to the postsynaptic neuron. Uni means it is one directional, right? So I mentioned neurotransmitters, so now I will talk a lot about the neurotransmitters because it is very important to understand this factor and the functions of the neurotransmitters. Are chemical messengers that transmit signals from neuron to the target cells across the synapse. And these neurotransmitters are produced in the presynaptic neurons and released in synaptic cleft. Synaptic cleft, you know, this is a gap between the presynaptic neuron and the postsynaptic neuron. And these neurotransmitters stimulate or inhibit the postsynaptic neurons. So here you can see the process of neurotransmitter action. I won't stop on this. And I will focus on individual neurotransmitters and its functions. We have a lot of neurotransmitters in our brain, in our body, but we are interested in major, very specific neurotransmitters which are playing role in most of the mental disorders. And we have specific neurotransmitters, specific effects. Here you can see these major neurotransmitters we are interested in, and these are adrenaline, which induces fight or flight effect. You know, this is the neurotransmitter. This is a substance which is released during the activation of autonomic nervous system. That's why it induces the fight or flight effect. It is produced in stressful situation, and of course it has the effects on heart. It increases the heart rate. It's because of the autonomic nervous system activation. It increases the blood flow, and it leads to the physical boost and heightened awareness. The next is the noradrenaline, which plays a role in concentration, attention. It contracts the blood vessels and increases also a blood flow. A very important transmitter, it is a dopamine, which is playing a role in motivation and pleasure, and we will talk today about this, the role of the dopamine in the substance use disorders. It has a very important role. The dopamine and the dopamine pathways are playing a crucial role in mental disorders and substance use disorders. Another very important neurotransmitter which is involved in the mental disorders is a serotonin, which is regulating the mood. It is the hormone of happiness, as you know, and a low level of this neurotransmitter causes the depression. Then the next neurotransmitter is GABA. GABA is a principal and major inhibiting amino acid and neurotransmitter in our central nervous system. It is inhibiting the anxiety, and all the anti-anxiety drugs target the GABA receptors or enhancing the GABA release. Acetylcholine, which is involved in learning, and as you know, Alzheimer's disorder, this is a very dangerous disorder of elderly patients, which is a type of a dementia. And the deficiency of acetylcholine caused the memory loss, so it is also responsible for the memory. The next very important neurotransmitter, which is amino acid, is a glutamate. Glutamate is the excitatory neurotransmitter. It activates the CNS. GABA is having a calming effect, and the glutamate having effect of excitement. It excites the CNS. And plus glutamate involved in the memory and learning. And a very important neurotransmitters are also endorphins, which chemically resembles the morphines. And you know that morphine, we use it clinically to relieve the pain. And endomorphins, we have these evolutionarily evolved mechanism to relieve pain. And evolution gave us these neurotransmitters like endorphins to relieve pain and give us euphoria. It is also giving us euphoric effect. So these are the major neurotransmitters which we have to focus on when we are talking about the mental disorders. And dysregulation of these neurotransmitters led to the different mental states and different mental disorders like schizophrenia, bipolar disorder, depression. For example, high level of dopamine may lead to the schizophrenia. Even we have the dopaminergic hypothesis of the schizophrenia. Low level of serotonin leads to the depression, as you know. High level of dopamine, noradrenaline may cause the bipolar disorder. And so different levels and concentrations, abnormal levels and concentrations of these neurotransmitters cause these disorders. Well, you might ask, why so many neurotransmitters? Why we need these neurotransmitters? But we have not only the neurotransmitters, but we have the receptors, specific receptors for these specific neurotransmitters, and plus we have the subreceptors for these specific neurotransmitters. So subreceptors are slightly different versions of the receptor side for the neurotransmitter, and why we need these subreceptors, subtypes of the receptors for the specification of the neurotransmitter effect and more refinement effect of the neurotransmitters. That's why we need these subreceptors. For example, dopamine has at least 5 subtypes of the receptors which are located in different parts of the body. But in brain, mainly located dopamine D1 and D2 receptors. So mainly we are interested in D1 and D2 receptors of the dopamine, but the rest are located in the different parts of the body. Of course, it means that they might have the different effects on a body. For example, you know that the dopamine receptors you might also find in a heart. That's why we use the dopamine to increase the blood pressure, for example. This is a different effect of the dopamine, right? It's different from the function that it has on the brain. When we are talking about the neurotransmitter, we have to talk about the function of the neurotransmitter. And first, the neurotransmitter should be released to initiate its function. So when the neurotransmitter is released, it's sending informational signal. So neurotransmitter is released in response to the sensory information. When the neurotransmitter is released, it produces the behavioral changes. Okay, so now I would like to connect the neurotransmitter with its function and with the effect on the behavior. The more release of the neurotransmitter we have, and the different behavioral effect we might get. Neurons are grouped together by the type of the neurotransmitters they release. For example, we have the neuronal pathways, different pathways, and these pathways have the specific names according to the neurotransmitter which they are released. For example, we have the dopamine pathway. It means that we have dopaminergic pathway. It means that this dopaminergic pathway is built up with the dopamine receptors. Here you have the same neurotransmitters with its effect. And now I would like to explain in more detail the function and localization of these major neurotransmitters. For example, acetylcholine. Primarily, we found acetylcholine in the brain and in the spinal cord, and the target organs for the acetylcholine is the autonomic nervous system. We have two types of acetylcholine receptors, nicotinic receptors and then muscarinic receptors. So nicotinic receptors mainly found in neuromuscular junctions, so they have their effects on the muscles, and muscarinics are found in the brain. So muscarinic receptors and the acetylcholine, when it binds to the muscarinic receptors, produces effects on the brain. And the indicated effects of the acetylcholine are excitation or inhibition of a target organ. It depends on what organs they are. They have to influence. And essential function of the acetylcholine is movement of muscles, and when it binds to the nicotinic receptor, it produces the movement and contraction of muscles. And as I told you, it is as I mentioned, it is very important in learning and memory. So when the acetylcholine binds with the muscarinic receptor in the brain, it produces effects on the memory and the learning process. Norepinephrine, which is the epinephrine in peripheral nervous system, also the hormone adrenaline. It is chemically almost similar to the dopamine and serotonin. You already know these are also neurotransmitters. Norepinephrine located in the brain and spinal cord, and certain target organs are heart and lungs. So we have two types of norepinephrine receptors, alpha and beta norepinephrine receptors, and the indicated effects are primarily excitatory. It activates the autonomic nervous system. I mean, when the autonomic nervous system is activated, the norepinephrine is released and induces fight or flight effect. So we have overarousal, cardiac issues. When it is released too much, even the mania, it can induce the manic state. When it is released too very low dosages, we have underarousal, depression, and cardiac issues. So I would like to mention that not only serotonin plays a role in the depression, but also norepinephrine plays the role in the depression. So low levels of norepinephrine can also be the factor for the depression. Dopamine, it is found in the brain, but of course not only in the brain, because we have different subtypes of the receptors in the different parts of the body. The location of the dopamine also in the limbic system, substantia nigra, frontal lobe. We have five subtypes of the receptors. And when we have too much of the dopamine, it induces the schizophrenia. When we have too little levels of the dopamine, it induces the Parkinson disease. So as you already noticed, the levels of the neurotransmitters determine different types of the disorders. Serotonin, also located into the brain and the spinal cord. As with other neurotransmitters, here we also have the different subtypes of the serotonin. For example, 5-HT1A, 5-HT1C, 5-HT1-2, but there are at least 15 subtypes of the serotonin receptors, but we are interested in more in 5-HTA1 because this is located into the brain. So, indicated effects of the serotonin are inhibition and excitation, so depends on the situation. As you already know, it is important in depression. Also, serotonin involved in the sleep-wake cycle. It regulates the sleep, digestion, and emotional arousal. Too much of serotonin can cause the serotonin syndrome. It is a very dangerous disorder. And for example, when we are treating the depression, we have to be very cautious with the dosages of the antidepressants. For example, in psychiatry exists the group of drug SSRIs, or selective serotonin reuptake inhibitors, which increasing the levels of the serotonin in the synaptic cleft. And if we prescribe too much or too high dosage of the drugs, we might induce the serotoninergic syndrome, which is a dangerous side effect of the drug, which might cause the confusion, twitching, trembling, dilated pupil, irregular fast heartbeat, and even in a very very severe case, even it might have the lethal outcome. But of course, it's very rare, but it might also happen. I talk about the GABA or gamma aminobutyric acid. It is an amino acid, which is still a neurotransmitter, predominant inhibitory neurotransmitter. And deficiency, of course, it is regulates and decreases the CNS, and deficiency of GABA may be related to the epilepsy and the seizure disorder. And to these GABA receptors binds the alcohol. That's why the alcohol is a depressant drug. First, with low dosages, alcohol induces the sedative effects. That's why when we drink alcohol, we becoming sleepy. It's because of this effect, because the alcohol binds to the GABA receptors and indicates and induces the similar effects of the GABA. But when you chronically use the alcohol, then alcohol gradually kills the GABA receptors and then the neurons. And then you wouldn't have the same effects. Then you might have the contrary effect. You might induce the insomnia because of the chronic usage of the alcohol, because you're killing the GABA receptors, and the GABA induces sleep also. Besides the GABA receptors, alcohol also acts on dopamine, norepinephrine, and serotonin receptors. Well,
I'm sorry, doctor. Doctor,
yes.
Why
Yes,
is
yes.
there a fan next to you? Aren't you supposed to feel cold now?
Sorry, sorry.
Why is there a fan next to you?
Next to me, what? I can't understand, my dear.
Why
Can
is
you
there
write down
the fan next to you? You're right.
fan? Yes.
Yes, but now it's cold in Georgia. Why are you putting it next to you?
Ah, no, it's just we forgot to get rid of this
Yes, yes.
from the room.
مضبوطة.
No, yeah, yeah, it's off-topic question. Okay, there are drugs which are mimicking GABA, and these drugs we are using to treat the anxiety. These are anti-anxiety drugs, and these drugs are benzodiazepines. So these benzodiazepines acting or enhancing the GABA and treating the anxiety. So too little of GABA, this neurotransmitter, cause the anxiety. Too much cause the oversedation or over relaxing or of muscles. So, we can't treat the anxiety with the benzodiazepines. Of course, when we know the proper dosage of the benzodiazepines, we can use it as a treatment of the anxiety disorders. Next is the glutamate, which is a principal excitatory neurotransmitter. It's critical for learning. And We have NMDA receptors for the glutamate and may play a significant role. This is a new information for schizophrenia. We had before the dopamine hypothesis. Now the researchers found out that the glutamate might also play the role in schizophrenia, which disrupts the regulation of dopamine, norepinephrine, and serotonin. I mean, abnormal levels of the glutamate might be the reason of the symptoms of the schizophrenia also. So glutamate affects memory, affects arousal, and affects the processing of emotions. Next is the glycine. Glycine is an inhibitory neurotransmitter, which is found in the spinal cord and in the brainstem, and it regulates the motor activity. It regulates the motor activity. For example, if the patient has the hyperkinesis or the irregular movements or unwanted movements, the glycine might reduce this hyperkinesis. We have also a neuromodulators. Neuromodulators are helpers of neurotransmitters. They do not directly excite or inhibit the postsynaptic neuron, but they regulate the release of the neurotransmitters, increase or decrease the release of the neurotransmitters. For example, if there is too much of the neurotransmitter in the synaptic cleft, the neuromodulators decrease the levels of the neurotransmitters. If it's too little, they are increased. And we have the peptides. Endorphins, as I mentioned, are the peptides. Peptides, as you know, are the chain of the amino acids. And endorphins, as I told you, is related to the pain regulation and the feeling of the euphoria. Because of the endorphin, we might feel high, for example. I feel high. You might know this term, right? When a person feels euphoric, he feels the high
Doctor, what
state
did you
of
say
mind.
now?
Sorry?
Sorry, what did you tell us now?
Endorphins, about the feeling of high.
Ah, okay. Then when we say we are high, it's because of this.
Yeah. Because of the endorphins, yes. Sometimes you have this mind state when you are euphoric, you're happy, you feel high, for example, or for example, when you're in a club, you're dancing, and I'm not telling now to when you are taking the drugs. Without drugs, you might feel high, and it's because of the endorphins. The rest of the peptides, substance P and the neuropeptide Y, are also important, but not as important as the endorphins, for example. They also regulate the metabolic functions. For example, neuropeptide Y regulates the appetite. Now I will focus on the brain itself. I talk about the neurotransmitters. Now also we are interested in the brain functions and the regions of the brain. Brain itself divided into two hemispheres, as you know. It is a very basic knowledge, but I want you to recall from your memory. Left hemisphere, right hemisphere, and of course these hemispheres have its specificity. I won't stop now on these specific functions of the hemispheres. Itself, this brain is divided into different lobes, and each of the lobe has its specific function. So for example, why it is important for the psychiatry. When we know the specific function of the different lobes, and when we know that the specific neurotransmitters or the neurotransmitter pathways are in this specific brain region, and this brain region is working abnormally, we know what type of functions are suffering, right? For example, if we have damaged frontal lobe, there might suffer the planning, the reasoning, the problem solving, the social skills. Or for example, if we have problems with the temporal lobe, we might have problems with understanding, with language, with hearing. For example, child psychiatric disorder, and the very common disorder nowadays and very actual disorder is autistic spectrum disorder, as you know. So we have problems with the temporal lobe in this disorder, and that's why understanding, language, and hearing is suffering in this disorder. Because of the problems with the temporal lobe. So this is a linkage of the brain regions, the functions, the specific functions of the brain regions, and the mental disorders. So I talk a lot about these disorders, neurotransmitters, its functions in relation to the disorders. Now I would like to talk about the theories, cognitive theories, which is very important also not only for psychiatry but also for the psychology. But psychiatry also shares this knowledge from the psychology about the cognitive development of the personality, because this is important, the stages of cognitive development for the psychiatry, because the person might have some problems with the development stages, with the cognitive development stages, and this might be the indicator for us to understand what type of problem the person has and what type of mental disorder can be because of these cognitive stages, developmental problems. So first scientist who developed these stages of cognitive development was Jean Piaget. It was the Swiss psychiatrist, as I remember, yes. And the Jean Piaget's theory of cognitive development explains how a child constructs a mental model of the world. So, what was his theory? He argued that intelligence is is not a fixed trait, but intelligence is developed according to the biological maturation and interaction with the environment. So we are not born intelligent, but we might have some basic structures inherited in us, which help us to develop our intelligence via the biological maturation and interaction with the environment. Of course, it is not necessary to be true, but this is one of the major hypotheses the psychiatrists and psychologists based on when they are analyzing the cognitive stages of development. As I told you, according to Piaget, children are born with a very basic mental structure, which is inherited and has a potential for evolvement. And because of this, our intelligence can evolve and develop because of these inherited mental basic structures. And Piaget called it the basic schemas. We have these inherited basic schemas. According to Piaget, the cognitive stages divided into several phases. The first is the sensory motor stage, pre-operational next, and another one concrete operational, and the formal operational. So what is the difference between these stages? The sensory motor stage, according to Piaget, starts from 0 to 2 years old. And at this stage, the baby trying to coordinate the senses with the motor response. The baby is curious to the sensory impulses and perceives the sensory impulses from the world. At this stage, the object permanence developed. The baby starts to memorize the objects. So it is absolutely sensory stage when the baby is having reaction only to the sensory stimuli. Next is the pre-operational stage, which starts from 2 years old to 11 years old. At this stage, the baby develops symbolic thinking, using the proper syntax and grammar to express full concept. At this stage, the baby understands the conservation laws. What does it mean, the conservation laws? When the child understands what is the difference between the volume and the mass. These are the conservation laws. Concrete operational stage starts from 7 to 11 years old. At this stage, the baby understands the time, space, quantity, and the child is more thinking independently. On formal operational stage, which starts from 11 years old and lasts until teenage period. At this stage, the child develops, or child and adolescents already develops theoretical, hypothetical thinking, abstract thinking, logic thinking, understands the meaning and the difference between these abstract words. What does it mean? Love, friendship, freedom. So at this stage, already the child becoming more mature. So schemas, I told you about the schemas. Schemas are inherited existing basic structures which help children to perceive the world. And because of this, the baby, when the baby perceives and understands the world, his mind state is in an equilibrium. Equilibrium means the state, his mind state is balanced. Uh, for example, and these schemas are like rules for the child and for the person. For example, for adult, what does it mean, the schema? Schema, it's like having instruction in your mind for your target behavior. I give you an example, it will be easier to understand. For example, when a person wants to order a meal or food in a restaurant, he has some schema in his mind, some instruction how to behave to get the food. And this instruction built up with the several steps. For example, on the initial step, the person should ask for the menu, then the person tries to find his preferable food in this menu, then he calls to the waiter or waitress to order the food, and afterwards he gets the food. So these are the necessary steps which are instructions, and this means the schema or script which is inherited in us. These are the rules of the behavior to get what we want. The infant schemas are a little bit different. Infant schemas are inherited reflexes. So infants have different reflexes, and these are schemas. For example, sucking reflex, grasping reflex, shaking a rattle. For example, this is a combination of the grasping and shaking reflex. So these inherited reflexes are the inherited schemas of infants. So when Jean Piaget observed this intellectual development, he observed that intellectual development can happen via the adaptation or adjustment to the environment. And this adaptation to the environment can happen due to the assimilation and accommodation. So assimilation is when the child using the existing schema to deal with a new object or situation. Existing schema is like a basic rule or it's existing knowledge. For example, when I got in a new situation, I have some basic knowledge how to behave in this situation or how to react in a new situation to adapt to this situation. So this is an assimilation. But for example, if I got in a new situation and my existing knowledge is not enough to adapt to the new situation, I need to gain more information for adaptation. So this is an accommodation. When existing schema or knowledge doesn't work, and we need to change to deal with a new object or situation. Change means to get more information. An example of assimilation can be like this. For example, a 2-year-old child sees a man who is bald on top of his head and has long frizzy hair on the sides. So he shouts, he's with his father and he shouts, clone, clone. So father is embarrassed because the man is not a clone, right? Even if he has the frizzy hair and resembles the clone, the man is not a clone. So father tries to explain to child that even if the man has the frizzy hair, similar to clone. He is not a clone, and the clone might have the different clothes, different costumes, and there are some other necessary attributes that fit to this clone. And when the father is giving this information, additional information to kid, then the kid absorbs this information, and the next situation he will be ready for adapting to the situation, and he won't call a frizzy-haired man the clone anymore, because this is an example of accommodation. Now I would like to talk about the Sigmund Freud, because Sigmund Freud was a founder of a very famous branch of the psychotherapy technique, which is a psychoanalysis, and even the psychiatrists using the psychoanalysis. That's why we learn in a psychiatry the
Yes, we took him in
psychoanalysis.
philosophy also.
Yeah, correct. Yes, so he was the father of the psychoanalysis, and he influenced a lot on people, the Sigmund Freud, by his theory of the psychoanalysis. So Sigmund Freud proposed, he also proposed that the psychological development in childhood take place in a series of fixed psychosexual stages. He also thought that there is a gradual development of personality through the psychosexual stages. And these stages he divided hypothetically in oral stage, anal, phallic, latency, and the genital stage. Well, these stages called psychosexual stages because each stage represents the fixation of libido. You know that libido is a sexual energy or a sexual drive or instinctual drive. And there is a fixation of the libido or the sexual energy on the different stages of the body. So when the person grows physically, the certain areas of the body becoming important according to his developmental stage. And these areas of the body might be the reason of the potential frustration or pleasure or both. So Freud belief was that the person's life is spinning around the tension and pleasure. So when the sexual energy is cumulative and accumulated, the person feels tension, and the discharge from this sexual energy gives us gratification or pleasure. So he thought that the sexual energy caused the tension, and discharge from this energy caused the pleasure, and the person spinning around this sexual energy. Each psychosexual stage is associated with a particular conflict that should be resolved before the individual can successfully advance and step up to the next stage. And the resolution of each conflict on each stage requires the investment of the sexual energy. And the more energy is expended to the particular stage, the more important characteristic of the stage remains with the personality when the personality matures psychologically. The more energy spent on each stage has its specific characteristics. So the more energy spent, the more personally gets more psychologically mature. But for example, if sometimes happens that the person is fixated on a particular stage. Fixated, it means that permanently invested this sexual energy to the particular stage. At this point, the person becomes childish. For example, if the person invested permanently his sexual energy his sexual energy or libidotic energy to oral stage, it means that he might become alcoholic because he is fixated on the oral stage. And this when he matures intellectually, he might have this childish characteristic of the specific stage. It's sometimes hard to understand this philosophy of Freud, and as to me, I don't really believe in this theory. All this is very hypothetical for me, but well, his theory exists, and lots of psychiatrists and psychotherapists follow his theory. So these are the psychosexual stages of development of the personality. So we have oral stage, anal stage, phallic stage, latency, genital stage. And each stage starts from 0 to 8. Yes. Do you have a question?
Clear, doctor.
Yes. Sorry? Should I continue, or do you have a question,
Yes, everything is clear.
Continue, doctor.
Okay. The next guy who also worked on the developmental theories, personal developmental theories, was Erik Erikson. Maybe you've heard about the hypnosis, right? You know this method of hypnosis, and the founder of the hypnosis was the Erik Erikson, and we have Erikson's hypnosis, Erikson's method of hypnosis. But besides the hypnosis, he worked on the psychological development of the personality. But the difference between the Freud and the Piaget was that he had the psychosocial development of the personality. So Erik Erikson thought that the personality develops through the psychological and social interaction. So a person interacts with the society, and if the person can adapt it to the demands of the society, he can develop into the complete and fully matured personality. If he has conflicts with the society on each stage, for example, he might have problems in adulthood. Of course, these stages also started into the infancy, and when during the infancy, of course, the person cannot be conscious, but unconscious conflicts exist in infancy. So these unconscious conflicts then turns to the conscious conflicts in the adulthood. So it will be easier for you to understand if I will give you an example of this chart. So these are the Erikson psychosocial stages, the summary chart. The first basic conflict that might happen during the psychosocial development is trust versus mistrust. It starts from 0 to 18 months. At this age, the baby is unconscious. So how this conflict should develop in the baby, what kind of social factors may influence on this unconscious conflict in a child. So this is a feeding, right? At this stage, from 0 to 18 months, the baby feeling comfortable if he or she is fed up, and have a very a very good caregiver. If he attached to a good caregiver, if he is or she is a fed up, normally at this point. At this stage, the child might develop this conflict if he does not have a good caregiver or he or she is not fed up enough. He might have conflict of trust versus mistrust. So children develop a sense of trust when a caregiver provides reliability, care, and affection. And lack of this will lead to the mistrust. Then we have a next conflict, autonomy versus shame and doubt, which develops from 2 to 3 years old. And it is related to the toilet training and the dressing. So why it is related to this basic conflict. At this stage, the child trying to become independent. The child wants to dress himself, go to the toilet himself, and if the caregiver gives him or her a chance to do everything independently, he develops self-confidence in his abilities, and he will develop into the autonomic personality if everything is okay. But if he is not having a good caregiver, if a caregiver does not give a baby a chance to do everything independently, the child develops shame and doubt into his abilities. So these type of stages and conflicts develops the personality and personality's mentality and psychology of the personality. The others are initiative versus guilt, industry versus inferiority, identity versus role confusion. It is good to know these stages of development, of Erikson's stages of development, because, for example, if we have problem in each of the stage, the other stage will not be developed correctly, and the person might have mental problems. For example, if in infancy the child develops the mistrust, the rest of the stages also will suffer. And in overall, when the child will grow up, he will grow up in a disabled personality. So that's why very important to know all of the stages, what kind of conflicts we might have on these stages, and what should the caregivers do to help the child develop in the normal personalities. And then when the person is already adult, what the adult should do to satisfy his needs. For example, when the person is already mature, we have the basic conflict, ego versus despair. This is reflection on life. And at this stage, when the person is already mature, if he had the previous stages normal, he will be a very satisfied. He will be very satisfied with his or her life. But if stages, he might have the despair, the conflict, which is a despair. He might not be satisfied with his or her life, and might get depressed, and even get in a deep depression, and sometimes even get and commit the suicide. So that's why it is very important to know. Well, we do not really have much time, you know. It's hard to put everything in such a such a small time. So now the patient-doctor relationship. Of course, you know that the patient-doctor relationship is very important in general medicine, and this is very important in psychiatry, even more important in psychiatry, you know, because you're dealing with mentally people. So, what is the goals of psychiatric interview, and why it is important, the interview? The effective interview and the good rapport gives us the uh, good relationship chance with the patient, and the patient will trust to a doctor, and the doctor will become a trustworthy for the patient. So it is good for the effective treatment of the patient when the patient trusting to a doctor. So the good psychiatric interview is very important. So what are the goals of psychiatric interview? Determining the nature of the problem, of course, like in any medical situation, to establish a relationship with the patient and to provide feedback and formulate the treatment plan. When we are talking about provide feedback, we are talking if the patient is in normal condition, he can follow you logically, he's in a remission period, and he is able to give you a feedback. If he is not in, for example, remission, and he's or she's hallucinating, we should provide information to the family member. We should involve the family member or the caregiver of the patient, and we should provide feedback from the family member or the caregiver. The interview has three main components: the beginning, the interview itself, and the closing of the interview. And three of these components are very important. So what are the major tips for the interview? Introducing yourself, greeting the patient by name, provide comfortable setting, put the patient at ease. The psychiatrist especially should be very supportive, attentive, non-judgmental, encouraging. First of all, until we will establish the psychiatric interview, we have to take a psychiatric history, right? So psychiatric history is a chronological story of the patient's life from birth to present. It is very important to know what is the condition of his life, what was, for example, his childhood, if this mental disorder manifested in his, what was the onset of the mental disorder. And the information should be gathered from the patient and from the other informants, because in psychiatric practice, we cannot depend on the patient, especially when the patient is hallucinating. We cannot depend on his information, right? That's why we need to involve the other informants to get the objective information about the patient. Of course, we need to do the mental status examination, and mental state examination includes the observation of appearance, behavior, attitude, speed of speech, mood and affect, thoughts, perception. Why it is important? Because, for example, speed of speech is characteristic sign of the different mental disorders. For example, rapid speech, it is a characteristic sign of the bipolar disorder in a manic state. Slow speech is a characteristic sign of the schizophrenia. That's why it is important to observe the speed of speech. The mood. If the person is in a low mood, we might identify that the person is in a depression. Perception. If the person has abnormal perception, we know that it is a characteristic sign of the schizophrenia. For example, delusions are abnormal perceptions of reality. So that's why it is important, very important, to do a mental state examination. It gives you very important information about the psychiatric patient. Except of this interview, the doctors using different techniques of relationship during the interview with the patient. So these are techniques you might combine or you might use separately. You can choose which is more proper for you. So, for example, these techniques are reflection. In this technique of reflection, a doctor should repeat to a patient in a supportive manner something that the patient has said, because you need to clarify the information which is given you by the patient. Facilitation. The doctors help patients to continue the interview by providing verbal and non-verbal cues. Silence. Sometimes silence is necessary when the patient is telling you some important information. It is good to be silent and to listen to the patient. Confrontation. In this technique, the doctor points something that the patient do not pay attention to. Sometimes patients missing the details that are important for the doctors. So we should confront this. And yes. I'm listening. Should I continue?
Yes, doctor.
Okay. Clarification. I will try to do it faster, but still it's not enough time. Clarification. In clarification, doctor clarify the details. In interpretation, they are trying to interpret the information to getting from the patient. In summation, doctors time after time trying to summarize what the patients are saying. In explanations, doctor explains to patient in understandable manner the treatment plan. And sometimes patients talking too much about one topic. And if doctor gets enough information about the topic, you might transit the patient from one topic to another topic in a gentle manner, you know. Self-revelation. Sometimes the patient's trying to reveal the doctor's private life. So you should partly reveal to the patient to get their trust, but it is not necessary to reveal or your personal details. Otherwise, the psychiatric patients are very manipulative, and they are manipulate with the doctors with their personal details. They are very, tricky guys, the psychiatric patients. So that's why the self-revelation is necessary only to get trust from the patient. Positive reinforcement is necessary. You have to reinforce patients positively to give you more and more information about his or her condition, and plus you can reinforce positively for their good behavior the psychiatric patients, because their behavior is abnormal, but this positive reinforcement, this is a part of the behavioral techniques, and it works really good with the psychiatric patients. Reassurance can work with the psychiatric patients only if they are in a remission period. If they have this light window period and they can perceive the logical arguments, only in that case you can reassure the patient. But For example, also it can be very helpful with a patient who is in a depression. Reassurance helps the depressive patients, and advice, of course. You have to be very empathic to the patient, not sympathetic, but empathic. Uh, you have to listen to the patient, but you should not be sympathetic. That there is a difference. And in psychiatry practice, you might have the phenomena of transference and countertransference. This rarely happen, but this still exists, this phenomena in the psychiatry practice. During the transference, for example, when the doctor gets the patient, for example, the patient might
Sorry, doctor.
get, yes.
But this PPT is from which chapter?
Which one? This is
The
a
one-
general psychiatry, guys. So
because I'm trying
will
to.
be enough this PPT,
I was trying to
Mhm.
continue with you in the book, but I didn't find the ideas you are explaining. That's why I'm asking.
No. Did you find the Kaplan and Sadok book?
We have the book.
It's expanded. There are each chapter is very big. For example, contribution to psychosocial approach. For example, it's about the Jean Piaget. It's in book, but not in a brief version, but in a big version of the book.
The book we use is Essentials for Dentistry, Human Diseases.
No. It's not in that book. I have to give you another book for psychiatry. It won't be there.
Okay.
Yes, we have it. You have it in the drive.
Yeah.
Yes, okay.
It's separate book of psychiatry, guys.
Okay, thank you.
It's not special for the dentistry. It's a general psychiatry for general medical students.
This is going
Yes.
to be many chapters together, today's lecture.
No, these PowerPoint presentations will be enough for you guys.
Oh, okay. So this is the only time you are going to give us?
Tell you to learn from the book, because these chapters are pretty much. So if you want to deepen your knowledge, of course you can use the book Kaplan and Sedok, which I will upload. But the PowerPoint presentations that I will upload, and this information will be enough for you.
Okay.
I mean, you will have the test. So these tests will be based on these presentations.
So we're going to have only one lecture with you, or we're gonna continue throughout the semester?
No. It's with me only one lecture. Today I'm done with you.
Okay.
Yeah.
Thank you.
Okay, thank you, doctor.
So you will have 3 PowerPoint presentations, guys. Today it's not enough time for me to deliver you the rest of the presentations, but these presentations I will upload. It will be
But
about
we
the
don't have it for our midterm, yes?
Yes, substance use disorders and anxiolytics and benzodiazepines and the hypnotics. So these PowerPoint presentations you will also have on the drive. So only these presentations will be included into your tests, the information from these PowerPoint presentations. Understood?
Okay, yes, thank you.
Okay.
Doctor,
right.
one more question, please, if
Yes,
you never
yes.
mind. The previous doctor, Dr. Sofu, told us that she will be preparing the midterm 1. Now you will be preparing the midterm 1?
No. I won't prepare the midterm. I just put only my questions in that.
Yes, you will put the questions for midterm 1?
I think so. I will ask them.
Because
Because Dr. Sofu told...
Sorry.
I will find out these guys, and you will be informed, because I'm not really competent to answer you right now. If
we are asking because the midterm 1 is on 24 November, And Dr. Sofo told us to study from the book Essential for Dentistry.
Mm-hmm.
We just
Okay,
want
I
to
will
know
find
which.
out this. Because I'm giving you just these three presentations, and I will prepare questions only based on these three presentations, guys.
You will be giving us only 3 presentations and you will be changed.
No, I will not change. No, these three presentations will be from this general psychiatry. You know, it's like
Say yes, case.
in your program, and the questions will be according to these presentations. There will be several questions, I think so.
Those presentations for the exam midterm 1 or midterm 2?
I don't really know if I have to put these presentations for meter 1, guys. I do not have this information, but I will find out.
Dr. Salome told us that we have till lecture 8, and now is lecture 9, so we have it for midterm 2, Doctor.
So maybe it's like I'm not informed what to tell you right now, but I will find out this and tell you. So if you're telling me that only 8 lectures will be included into midterm 1, logically, this psychiatry will be included in midterm 2, right?
Yes, right.
So
Thank
you know beforehand how many lectures will be included into the midterm 1, right? Are you informed how many lectures will be included in midterm 1?
Yes, they told us until the 8th.
They told us the
So
materials for the first 8
means
lectures.
that it will be on the second midterm, the questions. And I will upload these presentations. So, and the questions will be based on these presentations. So only if you want to deepen your knowledge, I will upload the book also, the brief version of the Kaplan and Sedek. It's a separate book of psychiatry for all who wants to learn psychiatry. But if not, it is not necessary. It is optional. I'm telling you that I will be based on the PowerPoint presentations, okay? But because it's pretty much information here.
Doctor, but don't give us this on the midterm because we have so many things.
Okay, I know. I will try. Okay. So transference, let me finish this, otherwise we do not have time anymore. So what does it mean, the transference? Transference is when the patient is emotionally affectionate to the doctors and have some emotions and projecting his or her feelings to the doctor. And countertransference is the contrary, when the doctor is projecting unconsciously his feelings to the patient. For example, if the doctor got the very beautiful patient, he might unconsciously have some erotic feelings to the patient, unconsciously, of course, and projecting this feeling to her. And this is a non-ethical issue. If something like that happened to doctor or to patient, by all means, you should interrupt the treatment of the patient and transfer this patient to the other doctor. Because the ethical committee will charge you because of this type of behavior. For example, if you fall in love in patient, it is not ethical issue. This is a countertransference phenomenon. And now I would like to talk about the ethical models of patient-doctor relationship. We talk about the techniques. Now we have to talk about the ethical models which are used in a psychiatry practice. We have 4 ethical models of patient-doctor relationship. Paternalistic, informative model, interpretive model, and deliberative model of patient-doctor relationship. Why will define each of these models? In paternalistic model, the physicians are like parents, you know. In paternalistic models, the doctor knows the best what is good for the patient, because the doctor thinks that the patient is not competent, the patient is sick, for example, and can't make a rational decision about his or her condition, and the doctor is the one who should make a decision about the treatment plan and about the fate of the patient. This is a paternalistic model, when the doctor is like a parent, and when the doctor is a superior over the patient. And the principle is that the doctor should make all decisions for a patient. This is the paternalistic model. In psychiatry, paternalistic model works really good, because psychiatric patients can't make any decision about their conditions, because they are not in their normal state of mind. And they cannot just judge properly their condition. They cannot analyze anything properly. So this paternalistic model is very good to use with psychiatric patients. So psychiatrists mostly are paternalistic, but it depends, of course, on a doctor itself, on a country. Some country prefers a different type of the models of the doctor-patient relationship. Another type of the doctor-patient relationship is an informative model, when the doctor provides all relevant information to patient or to family members of the patient, especially to family members in a psychiatric practice, because patient, if he is in a remission period, can make a decision. But if the patient is having a schizophrenia or hallucinating or having a bipolar or is in deep depression, he can't make any proper decisions. So we should involve the family members. We should provide all relevant information to make a decision. So this is an informative model of patient-doctor relationship. And the assumption of this model is that fact-value division of labor yields the best medical result. This is like a model which is happen between the partners. You know, the patient is like a partner for a doctor, and the doctor is sharing the information for making a decision together about the treatment plan and about the condition. The next model is the interpretive model, when the doctor should help the patients to articulate his or her values through interpretation and provide the intervention. And the last type is a deliberative model, when the doctor trying to help patient to deliberate through dialogue and the discussion to develop values which are objectively and truly worthy. It will be easier to understand via this diagram, these models of patient-doctor relationship. In paternalistic model, it means the doctor decides for the patient, I decide for you. In informative model, the doctor gives facts to the patient. I give you facts. In interpretive model, the doctor gives facts to the patient and help the patient to find his or her preferences. And in the deliberative model, the doctor gives facts plus tells his preferences to the patients. So, well, it's very individual which type of a model you will choose when you will deal with your patient. paternalistic, deliberative, informative, or interpretive. Or you can even combine these models, and it also depends on the patient. Some patient needs paternalistic approach. Some patient needs informative approach. Some deliberative. So it's very individual, and it depends and changes from situation to situation and from patient to patient. So that's it about the general psychiatry. So we do not really have for the other topics, but I would like to